Hi, my name is Jorid and I'm a critical care registered nurse in a 10-bed cardiothoracic medical surgical intensive care unit. Clinical governance is a systematic approach to maintaining and improving the quality of patient care within a healthcare system. Safety and quality goals, values and objectives are set and acted upon to improve the safety and quality of the healthcare for the consumers. The National Standards of Quality Healthcare Safety Standards cover areas where it is known that consumers experience high levels of harm and where there is good evidence of how safer and better care can be provided. We as healthcare providers need to ensure all links are made between health services, clinical and corporate governance, and the use of clinical governance to promote quality and safety through a focus on the quality assurance and continuous improvement. I've identified a problem in our workplace that challenges the clinical governance guidelines. Clinical debriefing in the intensive care unit. A little bit of background about my topic. There was a particularly eventful code in our intensive care unit, and a new staff member who was transitioning from the ward up into intensive care was involved. It was quite brutal, and resuscitation attempts weren't successful. Afterwards, I spoke with the registered nurse who was visibly shaken up, and she was on the verge of tears. And I asked how she was feeling, and she just was absolutely bewildered and very concerned for her practice, concerned for her patient, concerned for the family, etc. There was no follow-up after the incident, no debriefing. And the second incident, 3 a.m, the A&M and the doctor went down to a medical, which turned into a code blue. The patient actually had a do not resuscitate order on, but on ringing the physician actually ordered them to commence CPR. Which they did for an hour, which was unsuccessful. So the patient ended up passing away. On return to the unit, I asked the A&M how she was feeling, and she sort of shrugged it off, but with tears in her eyes, and said, "I'll get over it." There was no follow-up. There was no debriefing. There was no reflection after this event, and nor was any offered. So this really made me think, do we ever debrief in our unit? There's been various times when there's code or somebody's very unwell and things haven't turned out obviously the way that everyone's planned, and there's been no support offered. So why is this so important? After an adverse event, professional burnout is real, and it stems from the scope and severity of employment traumatization, unpredictable schedules, and extensive hours. Burnout can be minimised by interspersing clinical incident stress debriefing. So how can I promote a debriefing culture within the unit? So my methods. My supporting literature and articles were found using the main medical databases, PubMed, ProQuest, Sonal, and Google Scholar. My key search terms were intensive care, ICU, critical care, nurses, debriefing, coping, critical incident stress management, and my articles are limited to full text articles, English language, and then I actually widened the search to include emergency departments in that. So I took it on myself and to do a quick survey in the ICU where I work. So I surveyed 30 critical care registered nurses, was just up to understand the culture in our unit, and their autonomy was adhered to. So all the staff in the unit knew what debriefing was, and their answers ranged from clinical discussion with the team after an adverse event, an opportunity to get information, to have time to reflect and improve our practice, to get feedback and give feedback as well, sharing of information between colleagues about the processes, how staff can improve practice in the future, the ability to express yourself and how you feel and felt at the time, analysis of critical incidents, the sharing of information and explanations if needed for staff involved, and finding out any inconsistencies against the standard of practice. One participant said that debriefing was kind of important, and the rest of the participants said that it was very important. 100% of the people that returned the survey felt like there was not enough adequate debriefing after an adverse event, and 100% of participants said that they would like to see more debriefing in our place of work. We all know the importance of reflection and debriefing. Debriefing can stand alone as an educative method for clinical practice, and debriefing is an information sharing and event processing session conducted as a conversation between peers. The listener can be a therapist, counsellor, or professional peer that helps a group process the information being shared. Patients in the ICU are the sickest in the hospital. The high stakes and high stress healthcare environments are the most needed to be most supported. Critical incident has been defined as a self-defining traumatic event that causes individuals to experience such strong emotional responses that usual coping mechanisms are ineffective. There are policies in my workplace around clinical debriefing for patients and for staff. So how do I provide leadership to promote and evidence? Advances must begin with all healthcare constitutions, health professionals, federal and state policymakers, public and private purchasers of healthcare, regulates, organisation managers, and governing boards and consumers. Leadership initiative is needed to bring together staff members to acknowledge shared distress and accept responses to that distress, to affirm the group's human suffering, and to help the group cope. Acknowledging this is a deficit in the unit, I can begin to make the changes. Encouragement for staff to talk and initiate a debriefing. Ensure staff are aware of the resources available. Policy compliance and staff education. Implications and significance for practice. How can I change the practice? Encouraging policy adherence, position descriptions, liaising with the rest of the senior staff to encourage other staff members to seek help and to be an advocate for debriefing in the unit. Ensure that the debriefing culture is started right from induction and staff know where to access the information. To debrief within a few days of the incident, all staff should be invited to attend and address both medical and psychological issues. A senior clinician should lead the medical debrief and a trained individual should discuss the psychological issues. Pathways should be instituted to enable review of the medical issues. There should be a clear pathway of referral if psychological issues are identified. How is the unit initiating clinical governance guidelines for practice? Audit for practice. Performance appraisals and review of position descriptions, and also risk man identification and follow-up. How is our hospital or organisation initiating the clinical governance guidelines for practice? Our hospital has a National Safety, Quality and Healthline Services Progress Report, which aims to regulate an organisation-wide management of the systems for implementation and regular review of the policies, procedures and/or protocols. Specifically, number 1.3.1, that the workforce are aware of the delegated safety and quality roles and responsibilities. And point number 1.4.1, orientation and ongoing training programs that provide the workforce with the skill and information needed to fulfil their safety and quality roles and responsibilities. So how is the government setting the standards? The national standards were designed to protect the public from harm and improve the quality and care for consumers. In implementing the National Safety Quality Healthcare Standards, health services have put in place safety and quality systems to ensure the minimum standard of care are met. Gold Standard 5.1b, regularly seek feedback from the workforce about the quality of care and the quality improvement systems and their performances. And Gold Standard 5.1c, involving consumers and the workforce in the review of safety and quality systems and their performances. So what are the limitations? In our unit, we do not run a floating member of staff. Therefore, there is no spare staff member to cover potential meetings. The perceived unimportance of debriefing, the Australian shall be right attitude. The staff's not aware of the policies and resources available. Do they know that they're actually breaching policy by not initiating debriefing after a clinical incident? And are they aware of the counselling services available? There is no free staff member to come. and many staff are reluctant to come in on their days off. 12-hour shifts and family life taking precedence. Time. We're always limited in time in the intensive care unit. The feeling like you only need to debrief if something's gone wrong, and encouragement to debrief even if everything went well. The fear and anxiety of blame culture. Did I do something wrong? The unit's resources, the management's involvement and encouragement, and potential not understanding the importance to the staff and to the unit as a whole. In conclusion, at the core of clinical governance strategies lies an overt commitment to the principles of quality and safety. The transition of these principles into practice depends on a combination of knowledge, skills, and attitude. Identifying a problem in the workplace and its implications for practice is the first step in achieving the best possible outcomes for the consumers. Although the identified issues are numerous and diverse, common causative factors underpin failures to provide adequate care. Inadequate screening, assessment, risk identification, and care planning can result in failures to deliver care that meets a consumer's needs. To ensure that these standards are met within the unit and more broadly, we as clinicians need to understand the links between our own environment, making changes for the better, and the clinical governance guidelines by the Australian Commission of Health and Safety and Quality in Healthcare. The change starts with you.